Sinus lift can be performed with two different approaches, lateral and transcrestal. The B&B Dental Kit for sinus lift has been studied and designed specifically to perform transcrestal sinus lifts that allow the simultaneous insertion of the implants with an atraumatic protocol. Professor Discepoli teaches at the University of Siena, where he uses B&B dental implants, also developing projects of scientific research.
So good evening to everybody. This is Nicola Discepoli. I'm currently Associate Professor of Periodontics at the University of Siena in the Department of Medical Biotechnology. And I'm very pleased to can share with you some clinical pills about a transcrestal sinus lift techniques described by B&B Dental. I would like to thank B&B Dental for this opportunity, and I would like also to thank all of you for your kind attention. So if we look a little bit just to introduce this issue at the data available in the literature that describe the bone availability in the posterior maxilla for a favorable implant placement, I'd like to share these data published by Bram Stradler and co-workers just 10 years ago. This was a retrospective radiographic study, very interesting, because it clearly demonstrates that if we set an ideal condition to place properly and prosthetically guided our implants at posterior maxilla in an height of 8 millimeters and a width of at least 6 millimeters, these conditions, the frequency in which we find this condition in our patients is fairly low. In fact, this study demonstrates that a second premolar as well as a smaller site, the dimension of the alveolar crest, may call for bone augmentation procedures for proper implant placement in a substantial amount of dental patients. And furthermore, this study highlights that when both mesial and distal tooth adjacent to the edentulous site are absent, the placement of implants of adequate dimensions may be even more challenging due to the more apical position of the alveolar ridge, compared, of course, with the sites where both adjacent teeth are present. And as you can observe, almost between 20 and 35% of cases are those in which at the molar sites, those conditions, an height of more than 8 millimeters and a width of more than 6 millimeters were present. And if we want to go deeply about this clinical scenario, we know that after teeth extraction, a series of biological conditions takes part and determine a gross shrinkage of the bony crest. And this shrinkage goes in both directions, width of the residual crest and height of the residual crest. However, ridge resorption seems to continue on the long term with a highly variable progression rate both within and among individuals. And roughly, if we would like to didactically divide the two causes of this bone atrophy at the posterior maxilla, we could go from one side to the pneumatization of the sinus, and from the other side to the vertical resorption. Pneumatization is a continuous physiological process that causes the paranasal sinus to increase in volume. And these dimensional changes, as you can observe, are caused by pneumatization in the vast majority of cases. Pneumatization account of about 50% of the reason of bone atrophy at the second premolar, and about 20-25% of causes of bone atrophy at first and second molar. And these dimensional changes may lead, of course, to vertical and transversal bone deficiencies that significantly are able to limit the insertion of desired implant in terms of length and, of course, diameter. For these reasons, the edentulous posterior sextant represent one of the most critical scenarios to be rehabilitated by an implant-supported prosthesis. And the thus reduced vertical dimension observed in edentulous sextant, as I told you, are primarily associated with, of course, a more apical position of the ridge. Classically, if we look at the clinical history of the approach that have been described to overcome these limitations, these anatomical limitations, we classically fall in two different approaches. A lateral window approach that consists in an elevation of a mucopoietal flap with a transcrestal incision, with mid-crestal incision. After raising the flap, we approach the lateral wall of the sinus and we perform an operculum, an anthrectomy by burrs or piezo surgery. And thereafter, with a series of tools, we are supposed to elevate the Schneiderian membrane up to a desired level and place underneath a xenograft. The lateral window is covered by a bioresorbable membrane, and then the flap is properly sutured at the mid-crestal incision. Usually we are accustomed to wait between 6 and 8 months of healing before implant placement. When we decided to place implant simultaneously, we of course have to wait the same time. Conversely, if we direct to a transcrestal sinus floor elevation, we have to go to the classical description by Summer in the mid-90s, in which after a mid-crestal incision, we use a pilot drill to reach the floor of the sinus. And thereafter, with the progression of specific tools defined as osteotomes, we, by a process of malleting, we elevate the sinus floor by the intrusion of osteotomy procedure that elevates the sinus membrane, creating a sort of tent space, and this provides a space for the blood clot to mature, and according to the residual bony crest that help us to reach the adequate implant primary stability, we can leave the implant partially within this blood clot and wait between 4 and 6 months before loading. We have to underline that if we decide sometimes if the residual crest is rather reduced, to place a bone graft together with the procedure. But we have to note that the bone graft is placed blind into the space below the sinus membrane. The classical indication of this transcrestal sinus floor elevation is when we have a residual bone height between 5 and 8 millimeters. Below this procedure, we usually approach the residual crest with the lateral window approach. Which is the survival rate of implant placed with this clinical approach? So if we look at the data available in the literature, with the result of a follow-up more than 5 years, we have that survival of superstructure, so the prosthetic survival, is about 94-95%. And the figure of survival of implants, either with or without bone graft, we see that the value is really high, more than 90%, with a peri-implant marginal bone loss at more than 5 years of about half millimeter. This data suggests us that osteotome sinus floor elevation is a very predictable way to approach the maxillary atrophy. If we look at direct comparison between the percentage of survival after lateral approach and transcrestal approach, we see that using different data, but the result is almost the same, with more than 95% of survival at least 5 years for both procedures. More specifically, from a clinical standpoint, if we want to compare the lateral approach with the classical transcrestal approach, in cases treated with a residual bone age between 3 and 6 millimeter, we can observe that for 3 important surrogate variables, like marginal bone loss, bone radiopacity, and apical bone gain R, we have still no differences between these two procedures. The marginal bone loss at 1 year of observation in this randomized clinical trial attests that both lateral sinus floor and transcrestal are comparable. And they are comparable even for the whole bone radiopacity in terms of surface of implant completely covered by radiographic bone at 1 year of healing. And of course, if we look at the quantity of apical bone gain in this case, but only in this case and for this variable, the lateral sinus floor elevation resulted in more apical bone gain. Classically, the osteotomes sinus floor elevation that is built on the procedure of malleting by osteotomes, even though patients treated with this procedure unveil that they would undergo a similar treatment again, and they would recommend the treatment to a relative in more than 90% of cases, about 1/4, about 25% of individuals refers that experience some kind of trouble during the procedure, describing the procedure as unpleasant. And if we look much more in detail the patient-centered outcomes in a direct comparison between transcrestal sinus floor elevation and the lateral sinus floor elevation, we can see that the postoperative pain experienced by the patient during the first 2 weeks of healing, so a very early phase of healing, are almost comparable. And are almost comparable even the description of the procedure by the patient. About 60% of patients, according to this data, that underwent to the transcrestal sinus floor elevation, about 60% quoted that they have no problem to repeat the surgery if it would be needed. And if we look at the complication that usually this classical approach reveals, we can see that the most frequent clinical complication is the perforation of the sinus membrane. And only in very small cases, like 2% of cases, we have a postoperative infection. We have other complications derived mainly by the malleting procedure that is sometimes quite traumatic, like nasal bleeding, a blocked nose, the benign paroxysmal positional vertigo. So if we look at this data in a very comprehensive way, we see that the malleting procedure push patient to experience in a quarter of cases some unpleasant condition, and that we can have the perforation of the sinus membrane in about 20% of cases. To overcome this limitation, recently B&B Dental described and proposed this completely different approach to elevate the transcrestally, the floor of the sinus. And this sequence of WISE tool allow to reduce both the number, the percentage, the prevalence of complication in terms of perforation of the membrane, and from the other side to reduce the unpleasant experience that patient could have experienced and described with the malleting procedure. This compactor expander sequence is very easy to apply. First, we have to set more or less the initial height of about 5 millimeters. Let's see, for example, we approach the first pilot drill in which we just reach the floor of the sinus. Thereafter, we start to use this kind of expander with adjustable stop devices that are able to restrict the working action of osteotomes, of expander, to the vertical amount of residual bone, of available bone, thereby preventing the accidental penetration of the instruments into the sinus cavity and preventing the so unpleasant feeling for the patient to be mallet, which is the sequence of this compactor expander. So let's see that, as I told you, have 5 millimeter residual bone height. And we want to place an implant of 8 millimeters. So we start with a stop of about 6 millimeter, just to try to perforate the first millimeter of the sinus floor. And we start with this 2.1 diameter expander. Then with the same stop length at 6 millimeter, we enlarge the osteotomy with a 3 millimeter expansor. Thereafter, we follow the procedure with a classical sequence of white, yellow, red, and green for a millimeter diameter implant, B&B diameter implant. But we change the adjustable stop devices, and we add 1 more millimeters to be sure that completely atraumatically we are able to elevate the Schneiderian membrane without the risk to perforate it. Thereafter, if it's the case, we can add a bone graft, that in this case is a xenograft, particulated xenograft, with a specific compactor. And then we add at the final length of the implant itself. So let's see briefly first example in which we have to place number 16. So we perform a mid-crestal incision. We elevated a full periosteal, mucoperiosteal flap. We unveil the bony crest underneath. And Thereafter, we are ready to perform this expander procedure. The first bar is a pilot drill, and this drill just have to reach the height of the residual bone crest. So if we have a 5 mm of residual bony crest, we have to go at least at 5 mm with the pilot drill. And thereafter, we set our expander with the adjustable stop devices. And after the procedure is completed with the progressive enlargement of the osteotome by augmenting the diameter of the expander itself, we can skip to the implant placement procedure. After the implant placement, we can place our PMMA healing abutment, and with simple stitches obtained a complete primary intention healing. At the last picture in this slide, we have a 1 week healing of the procedure. Why do we need a 3P line implant? Well, mainly because we want to use an implant that with a rounded shape apex would help the maxillary sinus lift technique by reducing the risks of perforation, of course. Together with this rounded shape apex, we have a self-tapping system with a smooth macro design that help in the very first phase of healing, the early phase of healing, to reach the adequate bone primary stability. So let's see another clinical case in which I want to sum up a little bit what we have shared together until now. We have a missing 1.6 with a residual bone height of 5 mm. As you can observe, another important prognostic variable in terms of survival rate of implants is the shape and the direction of the floor of the sinus. In terms, we would like always to have a plain horizontal sinus floor, not an oblique one, due to the augmented risk that an oblique oblique floor of the sinus can augment in terms of survival of the implants. The residual crest is 5 mm. So as we will observe in this clip, in this movie, we want to place a 8 mm implant length. The procedure is quite simple. First of all, we with a 15C blade, we perform a mid-crestal incision going into the sulcus of the 4th and on the 7th. We have to be careful not to make any other defect during the incision. We take our P24 or a Pritchard and we elevate the flap, the mucoperiosteal flap, both buccally and palatally, as you can appreciate in the movie. And then we can go through our unique drill, that is a pilot drill. In this case, we use a 6.5 mm stop device, and progressively we go from the 2 mm diameters to the 4 mm diameter expander, from yellow to green, just to allow progressively the elevation of the Schneiderian membrane. And as you can observe, the procedure is really easy. We just use our tool with great capability not to be too much aggressive in terms of bone treatment, and properly we reduce the torque by which we place and we use the tool, and finally we place our 4 per 8 millimeter B&B dental implant. After we reach the dimension and the height we have planned, we suture and we place our PMMA healing abutment. This is a picture of 1 week healing. As you can observe, we obtained no sloughing, no fibrin clot, but a complete primary intention healing. So I hope that this brief discussion has helped and will help you to use these kind of tools, and I hope that in your next clinical case you will be able to reduce the unpleasant feeling of your patient and to improve the survivor with this expander modified transcrestal sinus floor elevation. Thank you all. Thank you B&B for this nice opportunity. Thank you.
Click on the link below and contact us for more information.